Thank you for the introduction, and I wanted to thank, of course, Franco Cecchin and Jacopo. We are just remembering together that the first time this meeting has been organized was in '87. You may not know it. And it was organized by John Goodwin and Fulvio Camerini and Professor Dollara from Florence. We were all young at the time, and many of the attendees today probably were not even born. But it's really remarkable that Franco was able to restart this tradition. So I'm very glad to bring your attention to dilated cardiomyopathy. We have talked a lot about hypertrophic, and now we are dealing with the dilated form. And I would like to focus on the most recent advances in this field, advances that have been made by the power of large studies, which were something new in the field, and the new powerful tools we heard something about yesterday by Caroline Hu, and how these have impacted our understanding of Mendelian dilated cardiomyopathy genes, somehow also modifier genes, and how these impact genetic testing. So just to remind you, we are dealing with dilated cardiomyopathy, which certainly is not more rare than hypertrophic cardiomyopathy. It's probably the same frequency in the population, and characterized in this case by dilatation and systolic dysfunction. So the natural history is slightly different. There is sudden death, but mainly congestive heart failure and need of heart transplant, although really the natural history can be very variable. And we know now that it's a genetic disorder by definition. So even if it's considered to be a mixed, a cardiomyopathy of mixed origin, it's a genetic disorder because in a significant proportion of cases, certainly there is a gene defect. It can be familial in 30 to 50% of cases. Usually it's autosomal dominant, although there can be different type of and pattern of transmission. And for some reason, also in dilated cardiomyopathy, there is a prevalence of males. But what I would like to discuss today are some concepts that yesterday Perry Elliott discussed. So the concept of overlap syndrome, which is kind of typical of dilated cardiomyopathy compared to the hypertrophic form, the so-called red flags that are very helpful to get their correct also genetic diagnosis, and also the fact that we are dealing with a large number of genes. Over 40 genes now have been associated with dilated cardiomyopathy, but unfortunately, so far, most of them with a very low frequency. So the reason is that while in hypertrophic cardiomyopathy, we all agree that it's mainly a disease of the sarcomere, in dilated cardiomyopathy, basically every single structure of the myocytes can lead to the disease. You can have sarcomeric gene, ZDIS gene, cytoskeleton, mitochondrial, ion channels, signaling proteins, transcription factor, and of course the nuclear envelope. So certainly there is a much higher level of complexity than in hypertrophic cardiomyopathy. So as it was anticipated yesterday, a major advance has been made in the last few months, I would say, when we realized that really Titin was the gene of dilated cardiomyopathy, so had an expectedly high frequency of mutation in this population. This is the paper that in which we contributed and led by the group of in Boston of Harvard, Cricket and John Seidman. So the interesting thing is that, as you know, Titin was a known gene for dilated cardiomyopathy. It had been described approximately 10 years ago with an important paper in Nature Genetics published by Ludwig Thierfelder and Brenda Gerul with a huge work. They sequenced this large gene and they reported the mutation in 2 families. So why it was so hard to replicate the data? Because Titin is an amazing gene. It's the largest gene known with over 350 exons that just to give you an idea is 10 times more, so 1 order of magnitude more than any large gene that we know. is the largest known human protein with 35,000 amino acids, is highly expressed in the heart, has a number of important functions, from the spring properties to the passive force, to regulation of the assembly and contraction of the sarcomere, and also rules in terms of signaling. So again, for 10 years, we knew that Titin had a role in dilated cardiomyopathy, but only 3 families were reported in the literature. So this was the power of putting together a number of institutions. This was a multi-center study, Harvard leading, our registry contributing with 150 families with dilated cardiomyopathy from Denver and Trieste, the Imperial College of London, the Mayo Clinic contributing with a large number of hypertrophic cardiomyopathy patients, and Seattle, the group of Seattle. And so approximately 800 patients have been screened for this huge protein. A large number of dilated cardiomyopathy, over 200 with hypertrophic, and a large number of controls. So we were astonished when we saw the data coming from the sequencing center, because we found so many mutations and various types of mutations. So we decided actually that it would be better to just concentrate on what is considered to be the most dangerous mutation, called radical mutation. So all the type of mutation that lead to a truncated protein. And even so, 25% of the patients with dilated cardiomyopathy had a putative mutation. Putative meaning after all the possible filtering you can think about, including databases, ethnical image control, and so on. And it was very interesting that actually in hypertrophic cardiomyopathy there was no significant difference with the control. So it seemed that Titin mutation were not very represented in this group of patients. But of course there is a caveat. And the caveat is that we actually only considered at that time truncation mutation. And actually it's possible that missense mutation that were not considered may have a major role. And this was the opinion actually of Henk Granzier, who is one of the leading biophysicists studying this protein. So the other interesting thing is that Titin had been linked to other type of diseases, for instance, muscle dystrophies. But all the mutations that have been linked to muscle dystrophy are located very, very clearly localized at the end of the protein. The controls, the mutation found in controls and in hypertrophic cardiomyopathy were kind of spread across the protein, whereas the dilated cardiomyopathy mutation were very well localized. And if you look at them, they are mainly localized in this area. And this is the A band, and they were virtually absent from the Z disc and the M band. And the fact that they were so associated to a specific localization suggested that there is probably a dominant negative effect rather than haploinsufficiency. So they are incorporated in the assembled protein, but unable to function normally. And they probably also cut out the signaling domains, and they most probably also disrupt the recoil of the protein. So looking at the phenotype, these patients were not particularly different from the other patients with dilated cardiomyopathy, with the negative patients, except for a few aspects. So for instance, one was that the histology suggested some weird aspect of the nuclei, something that we were used to see with the laminopathies, and the reason it's, of course, unknown. And that in males, the prognosis was much worse than in females. So we were very intrigued by this data. And at the same time, our group, working with the Human Genome Center in Seattle, sequenced together with the dilated cardiomyopathy group, also a group of patients with families with arrhythmogenic right ventricular cardiomyopathy. And surprisingly, again, so we found proportion in relation to this small number of ARVC cases, we found a significant number of putative mutation, and one of them was in a large family with a typical phenotype of right ventricular cardiomyopathy and was fully segregating. So we involved in the study of this particular mutation Hank Granzier at the University of Arizona, and he studied the function of this mutant protein and found that actually the mutation leads to an unfold protein, and the unfolding seems to lead to an accelerated proteolysis of the protein, and these in a clear pattern of degradation of the mutant, and we hypothesize that these proteolytic effect and degradation can trigger apoptosis and lead to the arrhythmogenic right ventricular phenotype. So two types of dilated, let's say, cardiomyopathies associated with the giant gene Titin. So not only Titin, but probably the whole Titin pathway is important. So this is another remarkable data. Another group had reported a novel gene recently, the RBM20 gene, a ribosomal small molecule. And actually the effect of this molecule was unknown, but it was found associated with dilated cardiomyopathy, one of the novel genes reported. So this group actually studied the function of this novel protein, and what they found is that actually this protein is a major effector of the processing of the Titin protein. So the mutation found in the dilated cardiomyopathy family was leading in an abnormal processing of the Titin protein in the heart. So at this point, we know that Titin and the Titin pathway is a major player, and that's a huge help in terms of transferring from the bench to the bedside these results. So, but there are other genes that deserve probably some attention. So one group of interesting genes is ion channels that have been always associated to arrhythmia. But we know that they can also cause somehow dilated cardiomyopathy. This is an old study we published in which we described this family with a very peculiar phenotype, mainly arrhythmia, conduction defect, and later in life, a dilated cardiomyopathy phenotype. But where we are very interested in see how this sodium channel gene could impact our dilated cardiomyopathy population. So we studied a large cohort of patients and their families, and we found that the frequency was typically in the range of 2%, so like the other genes previously known. But the remarkable thing is that basically all of them had a very strong arrhythmic pattern. Supraventricular arrhythmia, sick sinus syndrome, atrial fibrillation, but also a relevant number of patients had ventricular tachycardia, a conduction disease. So what we found is that the majority of these mutations were located in the highly conserved homologous S3 and S4 transmembrane segment. So the hypothesis that the mutation that in the sodium channel, as you know, a sodium channel can lead to a completely different type of phenotype, like Brugada syndrome or Low-QT syndrome. But in dilated cardiomyopathy, they probably lead to a disruption of the voltage sensing. So this brings me to another concept, and that again was brought to your attention yesterday by Perry Elliott. So these type of symptoms are red flags, and these are very important when you have to match the genetic testing of your patient with and try to get a diagnosis. That can be extremely helpful. Another example of red flags, in this case, some electrocardiographic pattern, inferolateral T wave inversion, and left ventricular arrhythmia can point to another type of dilated cardiomyopathy, which has been called arrhythmogenic left ventricular cardiomyopathy. These are data from the group of Dr. Chowdhury and Bill McKenna, who show that actually this patient may actually have a left form of right ventricular cardiomyopathy, which clinically cannot be distinguished by a typical dilated cardiomyopathy case. They actually do have fatty and fibrous infiltration of the left ventricle, and in 1/3 of the cases, you can find a typical desmosomal gene mutation. And this is what we can call overlapping phenotype. Another example of overlapping phenotype that we all know is the lamin and the so-called laminopathies. Lamin, as you know, is the major contributor of the lamina, which protects like a network, the nuclear wall, particularly in the heart, in the muscle, in the brain, and can lead to a variety of phenotype, one of them being dilated cardiomyopathy. Sometimes they also can overlap. So, and again, beside the overlap of skeletal muscle involvement, there are also red flags, very important in this case, to match with the genetic testing suggesting a lamin mutation and the phenotype of the patient. You may expect a high CK, conduction disease. Actually, if there is an atrioventricular block, in 30% of DCM patients may have a positive lamin mutation. This brings me to another aspect, and again, to the power of multi-center studies. We knew that in the case of lamin, these patients usually have a very poor prognosis and have a high mortality. And it was a remarkable study, the study done in which actually Dr. Pinto had a major role with a number of centers in Europe, and many of actually of the contributors that sitting here in this room. This group collected a remarkable number of mutation carrier of the lamin gene. They followed this patient for a long period of time, and they studied what they called the so-called malignant ventricular arrhythmia. So really serious arrhythmia, appropriate AICD shock, cardiopulmonary resuscitation, or sudden death. And what they found was really important also from the clinical standpoint. So they found that 80%, so almost 20% of these patients had a major arrhythmia, meaning sudden death, cardiac arrest of appropriate AICD discharge. They also found that they could distinguish 4 independent risk factors. Non-sustained ventricular tachycardia, just a mild decrease of the left ventricular ejection fraction, the male gender, and more severe type of mutation, so truncating mutation. And the remarkable other thing is that they found that actually there is a cumulative risk for these independent factors. So if you have just one, the survival curve is basically the same as other patients with dilated cardiomyopathy. But if you add just 2 risk factors, the survival curve drops. So this is very important in the clinical setting for us to decide when to place an ICD in these patients. And actually, the conclusions were that the lamin mutation have a poor prognosis and a high risk of sudden death, confirmed on a large population, that the carriers have a high risk of malignant ventricular arrhythmia, that these patients are the most likely to benefit from an ICD, and actually we have to consider an ICD regardless of the current guidelines for heart failure. So other interesting data come from a clinical lab, in this case the clinical lab of the Harvard partners in Harvard, and again another multi-center study in which they collected data from 7 referral centers. And in this case, they collected the data of which were the most frequent, the distribution of the gene and the mutation in a general cohort of dilated cardiomyopathy patients. And what they found is that actually the overall yield of genetic testing, and this was before the discovery of Titin, was around 17%. But if you look at the numbers, basically you reach 16% just by the lamin gene, the myosin heavy chain, and troponin. So these are, again, major players. And the other interesting thing that they found is that if you look at the distribution by age of the sensitivity of genetic testing, in patients that are over 40 and have no history of family disease, the probability to find a mutant gene is very low. So you probably should consider that in the clinical practice. Whereas if you look at the children, in young children, regardless of the family history, the probability to find a mutant gene is very high. So the overall diagnostic sensitivity in dilated cardiomyopathy based on data from a CLIA general certified lab are 17%. If you add the 25% of the Titin, we reach approximately 40%. And then the major players are the myosin heavy chain, lamin, and troponin. And unfortunately, this is what is called also the genetic noise. There is a 10% of mutation in which you really have no way to establish if they are true mutation or not. So another major advance had been the introduction of new technologies, as mentioned yesterday by Caroline Hu. Next generation sequencing, whole genome sequencing, and the powerful bioinformatic pipeline can lead to a totally new approach, both in research and in a clinical practice. So using the approach of exome sequencing, so full sequencing of all the exome in the human genome, two recent papers reported the discovery of novel genes. One from the group of Tim Olson, in which they study, and that's a relatively easier way to discover a gene, autosomal recessive dilated cardiomyopathy gene. And then the other group is the group of Nadine Norton and Ray Hershberger that together with the group at Seattle were able to find a BAG3 gene as a cause of dilated cardiomyopathy, so to discover a novel gene. But in fact, they didn't use the exome sequencing. They discovered this gene after unsuccessful exome sequencing by copy number variation. This is interesting because at the same time, the first study, another genome-wide study was done, a genome-wide association study on dilated cardiomyopathy. This was actually a European study. And these European studies, which considered two very large cohorts of patients and controls, discovered two modifier genes. And the interesting thing is that if you look, one of the modifier genes that they discovered, it's actually the same gene that Ray Hershberger discovered by exome sequencing. So which means it's possible that sometimes genes are important functionally for the heart. Sometimes they behave like modifier, sometimes they behave like Mendelian major genes. So, but let's switch now to the clinical impact. The group of Trieste made a very interesting study looking at the prognostic impact of family screening. So if you screen patients if you do a family screening and you compare sporadic patients that are coming to your observation because they have the disease, and the relatives of your patient with familial forms that are coming because you call them because they are at-risk relatives, the prognosis of the relatives is much better. Meaning that probably the fact that you are able, because of the family history, to catch them at an early stage may improve just because of the clinical screening, their natural history. But in terms of how to handle, which is the last point I wanted to discuss with you, how to handle the large amount of molecular genetic data we have, there are a number of guidelines that have been published both in Europe and in the United States. But the bottom line is that actually, yes, molecular genetic testing is a class 1 recommendation for dilated cardiomyopathy. Because now the expected results is a positive result in approximately 40% of cases with a noise ratio approximately of 10%. And it's justified also by the presence of family members at risk. This is just one of the examples of the new next generation tests that are offered. This is the pan-cardiomyopathy panel of Harvard. Just looking yesterday night at their what they offer now, from 46, they now offer 51 cardiomyopathy gene for the same price. And so it's remarkable that for the same price we were paying for a couple of genes a few years ago, we can test 51 genes. Now, there are issues with this problem because based on a study done by our German colleagues who did a proof of concept experiment using next generation sequencing in a group of families with hypertrophic cardiomyopathy and dilated cardiomyopathy, well, they actually found that besides confirming the known disease gene, they found like 30 possible predicted disease mutation in this patient that by any means every laboratory in the world will have considered to be a pathogenic mutation. So we find more mutations. The exon sequencing project has done another type of approach, has studied all the described dilated cardiomyopathy mutation in their large database of patients sequenced for, who underwent exon sequencing, and they found that putative mutation were present in 17% of the population. Making our job to discriminate between the real mutation and actually spurious variants very difficult. They suggested a new cutoff for the minor allele frequency of 0.04, and they calculated that we can expect that each of us will have 200 novel, mainly missense mutation, and everybody of us has approximately 300 mutant gene. And then Cricket-Simon and the Framingham and Jackson studies analyzed their cohort for 8 sarcomeric genes. And what they found is that sarcomeric potentially pathogenic mutation were present in 11% of the population. But it doesn't mean that these are really spurious mutation, spurious variant, because they found that actually these people had 2.3% more increased risk of having cardiovascular events. So there is something there. There is not just a benign variants. So just to close this discussion, and I apologize for being slightly over time, there are yin and yang in this situation. So we have a large number of genes, but we have very powerful new techniques. We have a low frequency of gene, and now it's up to 25% just with the addition of Titin. We have reasons now to test our patient, class 1 recommendation. We have red flags, overlapping syndrome that can address our search for toward a specific gene. We have way to re-stratify patients, particularly carriers of the LAMI mutation, and choose for them the appropriate therapy. And we have large databases that can help us to discriminate between rare variants and pathogenic mutation. However, the problems are that we are in front of such a remarkable variation of the human genome that we wouldn't expect. And therefore, the genetic counselors have now to face a new problem, that it's to follow up over time their mutation and maybe change the diagnosis over time. And so the genetic testing has to be considered a dynamic process. And that we need, it has been calculated that we need not anymore 100 controls. We need thousands of controls to be sure of our diagnosis. I will skip this concept. We can come back during the discussion, but this is what I wanted you to take home. So genetic testing in dilated cardiomyopathy is indicated because we know that we can get a positive testing in a significant number of patients. Now, it's indicated in the proband if you think that you change the management of the patient, but it's specifically indicated for the family members. That's an important point to keep in mind that I took from a recent review of Barry Maron about hypertrophic cardiomyopathy, but the principles are the same. It starts with a successful genotyping of the proband. If the proband is negative, there is no sense to genotype the relatives. It identifies non-carriers, so you don't need to follow up them. However, with the exception that you cannot exclude that there is a second mutation. Sometimes mutation may change over time their significance, and there may be errors. Identifies genotype positive, phenotype negative that can require adjustment of their management. It can help with the identification of malignant genes, multiple mutations. Now, one of the problems is that it has been started being used for assisted reproduction, and genetic counseling become a very important player. And with this, I will conclude. Thank you so much for your attention.
Thank you.
Congratulations for this very nice overview. I have a question about the Titin gene and the mutations. The paper is very wonderful. I am quite disturbed, however, by the fact that in the general population, they found that 3% of the control population also may have truncation mutation. So what do you think about that, and what do you think we can use in practice truncation mutation in the Titin gene?
It's a very important point. Thank you for your question, Philippe. It's true, and actually all these mutations were matched against the official, so the major databases and bioinformatic filtering. It's true, however, if we may consider that these overestimated the actual number of pathologic mutation, consider that we didn't consider missense mutation, which are a huge number. And so, and that still needs to be explored. You are right, and it's possible that in the future, in some of these families, we have to change the diagnosis, but still it remains that the number of abnormal mutation or truncation in this huge gene, it's remarkable. And it's not surprising because it's so big.